Afternoon. Can I just take a quick census? How many of the people in the room are GPs? Great. How many are nursing? And how many are allied health professionals? Pharmacists? Or others? Others. Lots of others. Great. Okay. How many of you are aware that North East Essex and Suffolk are in wave 2 of a population health management development programme with NHS England, which has started readiness preparation and will be moving into a 20-week delivery phase in the new year? Well, that's good. Brilliant. Fantastic. Okay. So I'm going to talk to you a little bit about population health management. And one of the things we always do is we go, why? Why are we doing this? Why are we even bothering? And the reason is that in my career, which started in 1981, as a medic, everything has changed. The type of patients we're looking after, the problems we're facing, bear no resemblance to the way I was trained and what I learned as a doctor in the 1970s. People are living longer. Lifestyles have completely changed. You've heard about all the technology and the revolution that's happening around us and the treatments. We are victims of our own success in health and care systems. In Bangladesh, in 1986, there was a particular area where they've been doing a longitudinal survey. 15% of people died of non-communicable diseases, i.e. long-term conditions. By 2006, 80% of people died of non-communicable diseases. But we've gone one better than that. We're not happy with just having one long-term condition. We've got to have multiple long-term conditions. And people talk about evidence-based medicine and they say, well, we need to apply the evidence we have from randomized controlled trials. 2 criteria from the majority of randomized controlled trial studies on long-term conditions. 1, anyone with a comorbidity is excluded, and anyone over the age of 65 is excluded. Actually, that's where our problems lie. An increasingly aging, elderly population with multimorbidity and frailty. That's our challenge. And population health management has become a central tenet of the NHS reform. It's a central tenet in Spain, in New Zealand, in Canada, in America, in Germany. I can give you case studies from around the world of how every health and care system now is trying to pivot and understand what it needs to do. And at the heart of population health management is a complete reframing of your perception of health and care. From one based on organisations and conditions, hospitals, GPs, A&E, community services, COPD, diabetes, Alzheimer's, to one which is based on understanding what is happening to people, their complexity and the risks they're carrying, and then using that information to actually sort out how your organisations work together and how you can bring what evidence we have about the management of conditions to best bear for people's complexity. So it becomes very personal and quite different and requires a whole new set of skills, capabilities, incentives, and way of working. It's driven by data, and it's about achieving, I presume everyone's familiar with the triple aim. Better outcomes, a better patient experience, and better use of the resources we've got. We will never have enough money to do everything. So we have to use what we've got to best effect. There is a 4th aim, which Lucian Leap introduced, and Michael West in Lancaster has pointed out is congruent with what the NHS needs to do. We need to bring joy back to work and re-establish an understanding that the people who actually deliver care need to be supported. One of the reasons I left my general practice and went into PCTs and then ended up at the centre working in NHS England was because every day I went into work wanting to do the best for the people in front of me. And every day the system stopped me. And I wanted to roll my sleeves up and try and change it from within. Naive maybe, but actually I feel really, really thrilled that with the new policies that have come out, there is an opportunity to actually put the front line as the most important component of the system to support in our endeavour to improve health and care and achieve the quadruple aim. And population health management is basically about quality improvement. The data is essential and it's completely insufficient on its own. You need to bring the human intelligence, the knowledge, experience and insight of frontline staff to bear on that data to understand what best to do for the population they're serving. The data will never capture everything. Algorithms are flawed. They always will be. But it's how you interpret that data and give it clinical meaning, professional meaning, human meaning that's most important. And I'm going to come on to this cycle of understanding your population. Population health management really, in my view, should be called population cohort management. It's understanding which groups in the population you need to apply your resources to, in what way to best effect with the limited resources you've got. So identifying opportunities, predicting what will happen, and then designing and implementing those interventions, measuring what's happening, and I can guarantee you that in a substantial number of cases it won't work. Every success is preceded by failure. And so what we must celebrate failure, identify it quickly and move on and start saying, okay, in a complex adaptive system, this hasn't worked, so let's try and do something different. The NHS still has more pilots than BA. What that requires is the infrastructure, the intelligence and the interventions. And at the heart of this is data. And it's about 10% about the data, but it's going to be 90% about the behaviour change of the professionals and the people receiving care on the front line. So a lot of this is actually using what many other industries have done, which is to make the user of the service much more empowered to take control over what happens. So how did I get here today? I ordered my tickets online. I've got them on my phone. I travelled down by train. I used Google Maps. And yet in the NHS, until recently, how much of that digital enablement have we had? And how much have we been able to use the data to support clinicians on the front line to do what's best? And this is a key slide because it's the functions that get delivered at each level of an integrated care system where you have integrated data. So at the top, you get the economic modelling and the actuarial projections. And this is actually identifying what will happen if you carry on doing what you've always done and make no changes. Based on historical data and trend analysis, it's standard in the life insurance business and in other industries. What will happen if we carry on doing what we've always done? And then actually working with frontline professionals to understand what would happen if we put new interventions in place. And then being able to track that difference between what would have happened and what is happening to demonstrate that nothing has happened because of your interventions. It is at a place understanding the segments and understanding rising risk. Where are the people that we need to reach because their risk is going to overwhelm our system if we don't intervene in a proactive manner? If we carry on being reactive and waiting for people to develop symptoms, we've lost the plot. At the PCN level, drilling down and looking at variation. Which cohort would you start on first? Why? What impact do you expect to have? How will you know you've had it? What's the intervention you need to put in place? And then ultimately being able to understand that at the personal level, what's happening to an individual across the continuum of care? Most of you will know that we can measure what A&E activity happened yesterday in most hospitals across the country. How many people at the centre know what happened in general practice yesterday? In community services, in mental health, in social care? Very few. But if we make that visible, we can demonstrate the value that those services are providing. You're going to get these slides, so I'm not going to go through this one for sake of time, so we can have some questions if you've got them. But what we do is bring together a linked data set. And key to this, almost the central key lock which unlocks this, is the fabulous data in general practice. We have the best electronic medical record in the world in general practice for primary care. And when you link that up and show what is happening to people across the continuum of care, the stories it tells are thrilling. Well, they are to me, because I think you can change the system with them. But you can start to look at this. Very, very simple initial segmentation of the population by demographic and by complexity. So on the left-hand side, the first blue box is the population scale. So in the top 11,000 young people 0 to 17, adults 18 to 74, nearly 40,000. And those 40,000 are taking nearly £10 million of the budget for this particular area of 70,000 people. This is how much money we spend across the continuum of care on individuals in a PCN. If you go then to the right-hand side, you can see then the per patient per year that's spent, £251 on adults 18 to 74. Does anyone know what the patient per year funding in the NHS is? Global funding, anyone know? I'm not sure I do. Somewhere between £1,500 to £2,000 a year. That's it. That's all we've got. So those people only consuming £251 means we can divert resources to the 666 highly complex adults, 18 to 74, who are spending £3 million at a per patient per year cost of 4,000. And there, those black boxes are their comparison with other PCNs in that geographic area. So you can see this particular PCN is doing quite well compared with peers in how it's managing some of the more complex patients, except in the younger age group of 10 young people. And there are only 3 interventions I would ask everyone to check have those patients got. Have they got a care plan? Have they got a care navigator? And have they been offered a personal health budget? Those 3 things are proven to improve care. And this is an actuarial trend based on the historical data, the projected yearly spend, and we can look at where that spend is going to grow over the next 5 to 10 years by point of delivery, which is in this case by demographic, or by specific drivers which we know exist in the system. But then we can drill down into segments of the population and start to pull out the patterns of ill health, the patterns of social determinants, the patterns of biopsychosocial problems that people are facing. And we can go into an individual's theograph and see what's happening to that individual and ask ourselves, could we have, looking at that pattern of care, organised care better? And invariably, when you sit down with the people who know most about care, the clinicians, they say, yes, we know how to do this. So what does population health analytics, what does integrated data do? Strategic insight, variation analysis. It supports outcome and value-based commissioning. And this is actually rewarding people. At the moment, our incentives are completely aligned to do the wrong thing. Capitated for general practice and payment by results for the hospitals, or payment by activity. It supports intervention design and can be used to track impact and return on investment. Where this is being used around the world, more and more money is being invested in primary care as people see the value that investing in preventative, proactive care creates in a health and care system. And that's what the NHS needs, in my opinion. And I hope it happens before I ultimately retire. Thank you very much for listening.